Good afternoon. We are back from a recess for our hearing of August 12th. We have the Gifford Hospital budget hearing next. I'll have our counsel swear in Mr. Costa and each of his testifying team members.
Hey, good afternoon, folks from Gifford. I'm going to administer the oath, and what I'll ask you to do is individually state your name for the record and then affirm the oath. And if we just go through each person that way, we have everybody's name for the record and have that taken care of.
Great.
Great. All right. So do you solemnly affirm that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth under the pains and penalties of perjury?
I do.
And your name, please. For the
My
record.
name is Michael Costa. I do. And I would hand it over to our CFO, Cheyenne Holland.
And I do, Cheyenne Holland.
And then our VP of Nursing, Sarah Simeone.
Hello, Sarah Simeone. I do.
Our CMO, Dr. Joshua White.
Hello, Josh White. I do.
Our VP of Clinical Services, Megan McCormick.
Megan McCormick, I do.
And our Vice President of Operations, Rebecca O'Berry.
Hi, Rebecca O'Berry, I do.
And we are also joined today by our board's treasurer and chair of the Finance Committee, Peter Reed.
Hi, Peter Reed, I do.
While there are others here from Gifford, we do not anticipate that any of them will be testifying before the board.
Okay, thank you. Witnesses are sworn in. I'll turn it over to Gifford for your presentation.
Thank you so much. We'd like to thank the members of the Green Mountain Care Board, Chair Foster, folks from the Healthcare Advocates Office for allowing us the opportunity to tell our story today. Rebecca O'Berry from our team should start sharing the slide deck.
Just one moment. My apologies, just one moment.
Rebecca, do you want me to give it a try or are you all set?
I'm having trouble because it's in a PDF.
Okay. I think I can fix that for you. Just give me 1 second.
You got a very busy looking calendar.
Oh,
Yes, thank you.
It's no rush. And if you want, you can actually email it to maybe someone on our team. I don't know if that would help.
got it.
Can you mail it? Okay. Mike, you can mail it to me or to Abby and we can get it up for you. Okay.
Can people see this?
Yes.
Got it. All right. Here we go. All right. Thank you, everybody. My apologies for the delay. There we go. So good afternoon, and thank you for the opportunity to speak today. I'm here on behalf of a team that's 10 months into likely the most significant and demanding turnaround in our organization's history. This isn't to us just a budget presentation. It's a story about transparency, grit, and a refusal to give up. Our message to the board today is simple. Gifford is in a turnaround. Gifford is worth fighting for, and we're doing everything in our power to make sure Gifford transforms, survives, and thrives. So when this fiscal year began, Gifford Healthcare was in real trouble. We were running unsustainable losses. Our days cash on hand were falling, and we were in technical default on our debt. Our EMR implementation had gone sideways. It disrupted everything from our revenue cycle to our morale. And add to that, our community and our staff were confused, frustrated, and scared after the Oliver Wyman report. It was turnaround time. So we took two first steps. One, we told the truth to our staff, to the community, and to policymakers. And two, we started building a plan, not to patch things up, but to turn things around. There's no benefit in sugarcoating it. We were in a turnaround, and we were in a crisis, and we owned it. Now, we knew that change had to begin immediately, and we had two overarching strategic goals. First, we have to achieve long-term financial sustainability. And second, we need to contribute in meaningful ways to Vermont's overall healthcare system. So to do that, we created three focused teams. First, a growth team to expand access to care and to reduce waiting times. Second, an efficiency team tasked with finding every opportunity to lower costs. And third, a Meditech team to rebuild our electronic health record and revenue systems from the ground up. On top of that, we've taken every chance to participate in reform. Gifford wants to be a partner, not a passenger, in improving Vermont's healthcare system. So the results are real and they're already visible. We've reduced our primary care waitlist by 600 patients. We've done this in 5 rural communities without increasing the number of providers. We've grown our inpatient census, helping to improve patient flow and potentially relieving strain on neighboring hospitals. Our inpatient census has grown from 8.7 average daily census in fiscal year 2024 to an average of 12.4 in FY25, and now 15 in July of this year. We're serving as a pressure release valve for other hospitals and improving system flow and keeping people close to home. We're right-sizing leadership with an eye to lowering administrative costs. We discontinued 2 low-volume services with minimal disruption, and we joined the New England Collaborative Health Network, lowering our supply and insurance costs. We're overhauling our charge master, guided by expert review, and we're rebuilding our EHR 1 unit at a time with care and accountability. The work I'm describing is not flashy, but it's vital. It's a disciplined, focused work, and we're proud of the early wins because they show we're on the right track towards our multi-year plan forward. Just this past week, we saw the most recent CMS star ratings, and we've moved up to having 4 stars overall and 5 stars in patient experience. It's proof positive of the progress that we're making. So the GMCB budget process has helped us as well. Our FY26 budget submission is grounded in 6 guiding principles. 1, compliance with your guidance. 2, inclusion. This budget reflects the voices of staff closest to patient care. Conservative assumptions. We're budgeting based on today's reality, not wishful thinking. We're sharing with you our actual performance for the year and how we think it will trend going forward. We're engaging in multi-year planning because our goal is long-term viability, not a one-year fix. We're being transparent about how Gifford Medical Center contributes to the broader Gifford healthcare system, which includes a federally qualified health center and our senior living facilities. And we're trying to have strategic alignment because we want to be a trusted partner in healthcare reform. This budget is a tool to drive accountability, not just a regulatory requirement. FY26 is a pivotal year. Our leadership team and board of directors is centered around critical questions. What actions must we take every single day to break even by year's end? How can we position Gifford to contribute meaningfully to Vermont's healthcare future? In what ways can we be a regional center of excellence? Who are our best partners to share resources? How will Gifford evolve and transform as it's done over the past 100 years? We're launching a new strategic planning process in the fall, and it must ask big questions. Where can Gifford lead? Where can Gifford specialize? And who are the right partners for our next chapter? We're not retreating, we're rebuilding with intention, urgency, and a deep commitment to our mission. Why? Because among many things I've learned over the past 10 months, one of them is this: Gifford and rural healthcare are worth fighting for. We're an independent healthcare system that can and must be your partner in reform. We're an FQHC with over 57,000 visits across just about 15,000 patients at a time when Vermonters desperately need primary care. We're a critical access hospital at a time when hospitals can and should work together to get patients to the right place at the right time at the right cost. We're a local and high-quality nursing home at a time when nursing home beds are at risk. And we offer more options in senior care and senior living with our adult daycare program in Strode Independent Living Campus. We're also a daycare serving 32 families and 44 children that allow people, including practicing providers, to stay in the workforce at a time when we need healthcare workforce. Now, I'm going to turn it over our presentation to our CFO, Cheyenne Holland. But before doing so, I want to say one more thing, and I want to say it with conviction. As I sit here today, after 10 months, despite all the challenges, despite all the hard works, I believe that we're going to make it. Not just make it, but we're going to come out better on the other side. I want to thank members of the Green Mountain Care Board and Vermont's hospital community for giving us all the support we need over the last 10 months. And we look forward to being an important partner in the healthcare conversations that we know are to come with you here and throughout Vermont. Cheyenne, I'd hand it over to you.
Great. Thank you, Michael. We can scooch ahead to the next couple slides. Good afternoon. I'm also going to focus on Gifford Healthcare, the enterprise, versus Gifford Medical Center, just the hospital, in the finance portion of our presentation. Before we talk about fiscal year 2026, we need to first look at fiscal year 2024. We ended the year with a $10.7 million operating loss. We booked the majority of this loss in the fourth quarter. August and September month-end, those month-end close highlighted the stall in our revenue cycle, and the early post go-live claims on our new EMR were beginning to age out. We needed to increase our reserves against our AR balances. We made subsequent adjustments since our year end was open for so long due to the technical default of our debt covenants. The longer it was open, our audit team looked at collectability and worked with us to increase our reserves and assess collectability on our older accounts. I started in Gifford at the end of August of 2024. One of the first things I did coming in was to assess our current revenue cycle performance. Post EMR go live, you fully expect to see increased days in AR, decreased cash during those initial months of the new EMR, and then eventually you start to see the improvement with high watermarks as AR starts to get processed, correctly adjudicated, and then move through the cycle. To compound the issue, Gifford outsourced their revenue cycle operations in January of 2024, shortly after go live, which also masked the performance issues within the EMR. One of the first things I did was I met with the outsourced team leadership just to figure out why aren't we seeing these improvements? And it readily became clear that they were struggling with performance because of the multiple errors and edits and rejections that they were working through on each and every claim. As we were diving into it, we saw that our clean claim rate was around 50%, which you would expect as an industry norm to be about 90 to 95%. When we did the deep dive, we realized that the issues in the EMR were problems that were widespread. There were errors in multiple dictionaries and multiple places within the EMR that contributed to these issues. So how did it happen? Our assessment of this is that during implementation, there was a significant amount of turnover, both pre and post go live at Meditech team itself, the implementation team, at our implementation partner, and at Gifford itself. This created a lot of handoff issues, a lot of inconsistencies in philosophy and in build and in maintaining sort of a consistent structure. And then at go live, there was a unusually large amount of manually uploaded data. And this impacted us because there's a lot of data entry errors that were not consistent. They were occurring randomly across the various parts of the system. We added things like required stops in some templates that weren't required for information, which then would get added to a claim, which would create a claim edit. We would have provider dictionaries that would have incorrect NPI numbers. We had transposition numbers. And this occurred, and I focus on revenue cycle, but these types of errors occurred in our people dictionaries, in our provider dictionaries, and our employee dictionaries throughout the entire organization. We had a technical default on our bond, on our debt covenants. We missed both our days cash on hand and our debt service coverage ratio in fiscal year 2023 and in fiscal year 2024. In fiscal year 2024, we were operating under a covenant waiver with our bankers based on our 23 performance. In fiscal year 25, we are operating under a forbearance agreement with our bankers, which took until June to finalize. And this is what's in place for the remainder of the fiscal year. Next slide, please. So fiscal year 2025, we are, as Michael said, in a financial turnaround. This is a multi-year plan, and fiscal year 25 is focused on stabilization. The first priority was to unstick our revenue cycle. We needed and still need to get cash in the door. Our days cash on hand declined month over month. We had a second year of a significant loss, which strained any cash reserves that the organization had, and our AR days continued to grow. Through a deep dive into our claim errors and rejections, we knew we needed to start the foundation, which was to do a complete evaluation of the charge master. We engaged a consultant through the Rural Health Redesign Center grant to assess the accuracy and completeness of the charge master. Before the assessment was complete, the consultants identified so many errors and inconsistencies that we all quickly decided to move away from assessment to mitigation and correction. As I mentioned, we had transposition issues. For example, we would have a 207 versus a 270 rev code go out on claims, completely denied. We had mismatched rev codes to CPT codes. We had incorrect taxonomy codes on and incorrect NPIs with our providers. We had incorrect unit issues, which then when units and charge per unit were being compared really skewed some of our results. We recognized that there were issues everywhere. So the very first thing we did was focus on the high dollar, high risk, and high impact departments. We're going through department by department. We're nearly complete with pharmacy, CT, MRI, and hospital cardiology services. And then rolling into Q1 2026, we'll be focusing on surgery and other high risk and high complexity areas of the organization. We also identified other dictionaries that were resulting in denials and missing charges. So it wasn't just the charge master, but that was the foundation and is the foundation for revenue cycle. Next slide. During 25, we, as Michael mentioned, we eliminated and combined services. We looked at our chiropractic care. Those patients can be served by other independent providers within the community. And we looked at urogynecology services, which were absorbed in other service lines. We had administrative consolidation. We eliminated executive and middle management positions. And we continue to look at efficiency across the organization. We aren't filling positions as soon as they come open. We look at each and every position. We review to determine whether or not, does this need to be filled? Is this the level it needs to be filled? Is this the right skill set? Is this full-time? Is this a fractional resource? Do we fill and hire this position? Or is this something, a service that we could purchase elsewhere? We did a review of our contracts across the organization. We continue to look at each and every one, ensuring that they're the right partner, that we're getting the right cost, that we have any opportunity to save and make reductions in our contracts. The most significant change was a reduction in the cost in our outsourced billing contract. The reduction represents a 30% fee reduction, which went into effect June 1st. And then we moved from NIA to NECHN July 1st. And we're really excited about this change and believe that there will be many opportunities to reduce costs through partnering with other hospitals in Vermont, leveraging the group purchasing, sharing resources. And we just feel like this is the right move. And we went effective July 1st, did not have any experience going into it to build into our budget. But what we've seen in the first few weeks of making this move, and I hear from my supply chain colleagues that they're already seeing expense reductions. Next slide, please. So we're beginning to see results in our turnaround plan. We approached our financial turnaround using consistent continuous improvement. We believe this is the best way to implement sustained change. We have shown quarter over quarter improved financial results. I want to highlight quarter 3 of fiscal year 2025. We show that we had a positive gain from operations in that quarter, and the gain was largely due to receiving an extraordinary financial relief payment from Medicaid for our long-term care facility in the month of June. Otherwise, we had a little bit of a dip in that quarter due to some variation in our own employee health plan. But otherwise, month over month, or quarter over quarter, we continue to make progress to our financial performance. We are measuring days cash on hand. We continue to see revenue cycle performance and performance in our volume at those 3 areas that Michael had mentioned earlier, where we're looking at our average daily census, growth in surgical volume, and our clinic volume. We're showing July performance. These are early indicators, and the month of July is the highest amount of cash posted in well over a year, showing the results of some of the improvements we have made in the revenue cycle performance improvement. Next slide, please. So as we look at fiscal year 25 and ramping up to fiscal year 26, we're going to continue through our revenue cycle work plan. We implemented an AI denial management tool in June and are already seeing significant and immediate improvement. This is all focusing on both new claims going out, but also we were able to run through a lot of the claims that had gone out incorrectly and then been able to make rapid change and corrections to those claims so to improve cash collections. And then going into this last quarter, we're going to do a focus on our inpatient denials management. As I mentioned, we joined NECHN, and we expect to see ongoing supply chain savings. We plan to transition our benefits the first of the year, and then our liability insurance as of October 1st through their program. Going back to revenue cycle, I meant to mention that we are moving our self-pay vendor to another platform, which will enhance patient experience, improve our self-pay collection, and improve access to our payment plan process. This tool will also assist our financial counselors to help our patients access our financial assistance programs in a more ready and seamless manner. We reached out to undo medical debt while they were presenting to the CFOs at VAWS. I actually have experience working with them through other clients in the past. I met them a couple of years ago and have recommended their service to folks over the years. I think this is a great opportunity for our patients. We know this isn't a financial windfall for us as an organization. However, we know that patients and that the studies show that patients avoid seeking care when they have bad debt and that they believe that their providers know and think that they aren't paying their bills, although we all know that's not the case. There is psychology behind it that it really improves overall care to your community by focusing on medical debt. And we are absolutely excited to partner with them. And as I mentioned, we are really excited about NECHN. We think that this will create a lot of great synergy across our organizations and looking at ways, and we fully plan to participate in as many of the initiatives that are practical for Gifford. Next slide. So fiscal year 26 is year 2 of a multi-year financial turnaround. So our budget assumptions were bounded by 2 main stakeholders. We used the Green Mountain Care Board budget guidance to create our framework initially in our budget, where we kept our rate to a maximum of a 3% commercial rate increase. We limited growth in commercial net patient revenue and an overall expense increase. We also needed to work within our forbearance agreement with our bankers, and our forbearance agreement through the end of fiscal year 25 requires us to have a day's cash on hand of at least 59 days. That was our lowest point, and we can't allow it to slide any further. And we need to have month over month from July, August, and September, income available for debt service needs to be greater than $1. So we took those as guidelines, and when we built our budget for 2026, we assumed, we asked ourselves, does this budget meet those standards for 6 months, and then 6 months of break-even performance for that period? The bankers have received our budget. They are still in discussion, and they have not necessarily agreed with our budget at this point in time. We are working with consultants at the requirement of the bankers that are stress testing our 26 assumptions. And they're also asking the consultants to identify opportunities and offer an opinion of, is it practical for Gifford to meet the original debt covenants, which is debt service coverage ratio of 1.1 and days cash on hand of 75 by the end of fiscal year 26? And if not, what is the timeline to get there? Our bankers also have the option to exercise a put in April 2026 and require us to redeem our bonds. They've indicated that they are more likely than not to exercise it. They're not giving us a definitive decision today on whether or not they're definitely exercising this put. And this is due to our performance, but also it's due to the very low interest rate that this debt has. So the combination, it makes it attractive for them to require us to redeem. So we are working on a refinancing strategy with the eroded financial position that we currently have. Ultimately, we need to have consistency in our financial performance. We need to show improvement, and we need to be meeting our budgeted assumptions. So we wanted a budget that we could hold our management team accountable to, and the assumptions that were realistic and achievable, with the expectation that we're going to outperform, not underperform, in fiscal year 26. So our assumptions, we built our assumptions based on our fiscal year 25 performance. We looked at, in some cases, the progress we had made during the fiscal year. So we set our average daily census to 13.75. We held our surgical volume flat. Our ED volume was set to just where we've been running, where we expected to project the year. And then we had some volume increase in our ED physician volume because we had missed charges for a couple of our providers that we ended up being able to rebill for between the time that we started to run our budget models and the final budget. So And our hospital's volume is increasing just consistent with those inpatient, outpatient, inpatient observation volume changes. At our FQHC in primary care, those volumes are based on the work of the team with opening up access, eliminating wait lists, reducing wait lists, as Michael mentioned. And there's one increase in one of our practices because we had a new provider returning from FMLA. And then just our clinics, we increased rheumatology because that was a service that was started in 24 that is continuing to ramp up. And then we removed some of the expense and revenue from our neurology service because we had provider turnover. And our long-term care is just based on current census. We did a 3% charge master and commercial rate increase across all our hospital and all of our clinic services. We did include an increase per encounter that we have received from Medicaid for the FQHC. And then we received MENEG's, the long-term care facilities, new Medicaid rate just last week, and so it is not built into the budget. But we do expect improvement in reimbursement and revenue in those other areas to support operations. We assumed a collection rate of 50%, which is what we're currently running is at 50% of charge, which then assumes that whatever rate we put into our charge master, we're going to collect that increase across all our payers. One of the things that created a little bit of noise in our budget is the shift from the Medicaid fixed prospective payment with the ACO sunsetting at the end of the calendar year and moving that under the fee-for-service bucket in Medicaid Q2 through Q4. And we assumed in our assumptions that this would just be a net neutral, that we would not receive any additional funding through it, or we didn't have any reduction in funding. Slide, please. Overall, our salaries, we budgeted a 2% cost of living, and we added a placeholder for market. It's like an arms race. So as other areas go up, other areas that increase their salaries, we have to look at the market and we have to at least be competitive in the market in order to not have increased contract labor costs. So we've made reductions in our FTE budget. From 24 to 25, we've had quite a bit of reductions. Some of this is related to having, in one of our lines of business, we outsource the management of our independent living services. And so all of those employees are under that organization's, under their operations. And we're seeing a lot of movement between our labor, purchase services, and contract services. So when I speak about contracted services in this case, these aren't like travelers where it's like a variable rate. It's more of a decision around, do we hire and purchase and provide this service, or do we contract with another entity to provide this service? And that happened with our radiologist and with our OBGYN group. Our benefits, as I mentioned, we are looking to move to the collaborative in January. The overall expenses going up is actually going to be less budget to budget based on the reduction in FTE. But our initial estimates from our third party was that it was going to go up on a per member per month spending up by 8%. We do encourage care at Gifford, and this is an area that we can mitigate our expense increase because where we have capacity, there's little to no additional cost to us to serve our employees. So we are working with our HR teams to encourage care local. So contract labor and purchase services in our budget, you'll notice there's a lot of movement across these buckets. 2.3 million of it is a change to our outsourcing of our management for independent living. That was salaries, benefit, and supplies on their P&L, on our P&L, and now it's under a contract management or a purchase service line. As I mentioned, contract labor for our new radiology contract. We had a radiologist who left, went to one of the other hospitals in Vermont, lucky for them. But he lived closer there, so we won't hold him. We'll still hold him near and dear to our heart. But we ended up having to contract for that service. And then our OB went from an employee to a contracted service. And then we built in just our basic assumptions from our GPO. Overall, our expense increase over budget is 2.5% over fiscal year 25 budget, with a slight decrease over our current year's projection. We did not implement or did not specifically identify reductions due to the GPO change. We were too new into it with just some high-level analysis that we didn't want to bake it into the budget. And there are a lot of unknowns still based on, kind of where supply chain is going and where some of the other risks to expenses are. And then in the 25 budget, when you look at a budget to budget review, there were line items that were reduced in the 25 budget in the purchase services and contract service categories. When we received our budget order, we took expenses out in some of the largest categories rather than going detail to detail on a line item basis. And some of these line items were reduced when we actually had a contract in place and were obligated for those expenses. So that's why there's some noise, I think, around the various categories of our expense. So next slide. So when you look at this, this is our combined P&L for Gifford Healthcare overall. We are on a combined basis closing our financial gap in fiscal year between fiscal year projected 25 projected to 26 by $5 billion through our current initiatives and through identifying and implementing new initiatives throughout the fiscal year, because we need to continue towards our march towards break even and then profitability in 2027. Next slide. So this is our combining P&L. These are our various business lines, with Gifford Medical Center being the first column, which is the detailed budget that the Green Mountain Care Board receives, which includes the Critical Access Hospital and our specialty clinics. But we also wanted to break out our FQHC, our long-term care, our adult day program, and our independent living. We do have a shared services department, myself, Michael, all of the executive team, as well as human resources, finance, revenue cycle, IT, quality, plant operations, laundry, linen, EVS, and materials management, and our childcare center all fall under the shared services, and these expenses get allocated out through these to these other organizations. So when we look at Gifford Medical Center by itself, we show that our net patient revenue budget to budget is 2.5% less than last fiscal year. And our total expenses budget to budget are growing just 0.7 on just the line on the Gifford Medical Center line of business. So as we're looking ahead, we're not asking for a higher commercial rate to assist with our turnaround. We're really looking at it just to offset any of new costs due to inflation in 26. That any of the big turnaround initiatives that we do, we are continuing to look at reducing expenses, becoming more efficient, and really our commercial rate request is just looking at, as our own costs, our per unit costs are increasing in this turnaround period, could we have enough of a rate offset in order to offset those increased expenses. We do know that as we go through our other non-core, like what are the services within our entire organization that aren't core to our mission, not core in our community, can be provided at a high quality by other organizations, we're going to continue to look critically in those areas. And we are looking for revenue improvements across all of our business lines. We had the Medicaid increase for the FQHC, which went into effect July 2025. We've increased our rates in our independent living facility. We had increased rate letter that we received in just last week for MENEG. And we received the extraordinary financial relief funds for MENEG, both in 2024 for 4.1 million and 2025 for 3.1 million. And we continue to look for cost reporting opportunities where we can maximize wherever we can the Medicare reimbursement through the various programs. Since we are very unique, being a critical access hospital, a federally qualified health center, and a long-term care facility. Slide. We want to maximize our expense reductions, leveraging the collaborative. We know that in the first 90 to 120 days, we'll receive reports identifying additional cost saving opportunities in supply chain on where we could really maximize under the contracts. We plan to participate in all the various programs that are being offered. And I think one of the other things that we really look at is, what do we need for a critical access hospital? A lot of times we don't need a full-time person. Sometimes we just need a fractional resource. So how do we find and recruit highly skilled resources on a part-time basis? And who can we share those resources with? And I believe that both the collaborative would be a great avenue for that. And then looking at, do we contract or hire for services? And then our other key focus area is our overall footprint. Do we consolidate further our services? Are we providing services in the right locations in our community? And where do we have opportunities to become more efficient?
So, I would just say we can stop sharing now. I'm really glad that we're done the talking point version of this presentation and we can get to what makes Vermont really special, which is having a conversation about where we're at and what we're going to do. There's a lot of opportunities out there. What we really want from the Green Mountain Care Board is to emerge from this hearing with our budget approved without modification, and to be a more trusted partner in the state's efforts to evolve the healthcare system. We think there are a lot of opportunities out there, opportunities to expand access to care, opportunities to get more efficient, opportunities to collaborate, whether it's with academic medical centers or other smaller hospitals through the collaborative, opportunities to create our own workforce. For example, we have a new nurse residency program in our inpatient unit that's got 8 brand new nurses there. It can help us leverage local folks instead of travelers. What we need is the opportunity to stabilize and the opportunity to get better. Our view is you do that through radical transparency. We come to you and say, hey, these are the books. This is what we've been through. This is what we're trying to do going forward. Board member Walsh has asked some really good questions over the last 2 weeks about how does this fit? How do our budgets fit with our community health needs assessment? Cheyenne had a slide up there about how Gifford Medical Center has historically been the engine that allowed us to flex to meet community needs, whether that's the federally qualified health center, the only nursing home in Orange County, and adult daycare, or further living options for seniors. I think we've got to get back there where the hospital is that strong engine, and then we can figure out what the right array of services and the right geographic footprint is. It's been a journey. It will continue to be a journey, but we're grateful to have partners, and we're ready to answer your questions.
Thank you very much for the presentation. I thought they were really valuable talking points and appreciate hearing them. I'll turn to Member Walsh for board questions.
Thank you, Chair. Thank you, Mr. Costa, for listening to the prior questions. You teed up my first. Thank you for your staff for the presentation. It's obvious you're doing some really important good work in your commitment to radical transparency, continual improvement. I just want to commend you for that. I think you're on a good path, a difficult path at a trying time. With your budget and your community health needs assessment, you talked about getting back to that and the redesign of your footprint. Can you just say some more about what you see as short and midterm priorities and how you're monitoring them?
Got it. And I want to be careful speculating on the record. There's been the reason why the presentation and slides contain financial information and less say quality or patient outcome information is because we've been very focused on how we get back on track and we consider patient safety and quality a given. I think for us, what we'd like to do is create work plans that reevaluate every single aspect of our business in FY26 and work with our board of directors to set what the priorities are. When I'm hopeful as we progress in our financial turnaround, we can get to those big picture questions of how the health system should work. I think we got to be best friends with our designated mental health agency. I think we need to figure out, my background includes a stint as CEO of an FQHC and home health and hospice agency. And so I think we need to figure out how to meet people at home. When I hear Medicaid talk about a global budget, that immediately makes me think, how do I get people out of our four walls and back into their homes and other spots in the community? And so I think we need to get to a place where we think, okay, instead of talking about all this stuff, what are we going to do about it? And who are our partners and what are our pilot programs? Right. And then it's really, even though we're small, we have an FQHC that includes mental health services. We have the critical access hospital. We have the senior living. Like, how do you use that as an advantage? How do you try to get people and understand how they cycle through the healthcare system? So I think we're probably, at some point in FY26, I hope we're pivoting away from urgent financial problems to, hey, how do you transform care delivery problems? And I think we want to be back here next year saying, here are a couple of things we piloted, and here are the metrics we chose, and here are the results. I worry we don't spend a lot of time thinking about how Gifford ended up, like where it ended up, other than trying to figure out how to improve it going forward and do a lot of speculating on previous management. But I worry that Vermont healthcare institutions get caught in the trap of good people doing good things. And so nothing bad can happen to us, and they can. And so we want to have a more disciplined approach of how do we pilot things? What are our key performance indicators? How do we know if they're successful? How do we report them out to people? And then how do we make more of it if it's going well? So I'd love to come back with slides that are more focused on that next year.
Great. That all sounds terrific. I want to make sure that we're doing everything we can within the state framework to support what you're doing, what you're outlining. It seems right on target. When you come back with that further detail, as you pointed out, I'm very interested in when we're transforming, can we document the transformation and the budget changes to our local community needs? And so just keep that focus when you come back, and if you don't mind, I'd really appreciate it. I was encouraged. My second question was about contracted services, but you already addressed this. I was going to ask about fractional staffing models, and it sounds like you're thinking about it and on there. I'm also encouraged by the collaborative and the potential savings with that. I know it's early days for your participation in it. I do have a little bit of a concern about the excitement of potential savings and those being overestimated. So I just wonder how much you're projecting to save. And then if those don't materialize, do you have backup plans for that?
So, Board Member Walsh, I couldn't agree more with your trepidation on this. My observation as a longtime Vermont public policy guy is we are really, really good at convening. We are less good at execution. And so I was very nervous about NECHN. Now that we're board members, I'm really grateful for Joe Wooden and Peter and other people's leadership on that. But your point is exactly the reason why we didn't book savings on the GPO. We have a dollar value, but we felt like it's speculative between the fact that it's new and none of us have worked together. And there's the whole tariff thing going on right now and inflation coming to you and saying, oh, yeah, we're going to save this much money on it, 6 figures plus, just seemed irresponsible. Because we think part of being a trusted partner with the state generally and the board specifically is if you can say you're going to hit a number, you got to hit it. Because when I look at our previous budget submissions, there's a lot of variance between submission and performance. And we want to get in a cycle where there's a tight linkage between submission and performance. So we can hold ourselves accountable and you can hold us accountable. So we book 0. It feels like contingency funds because we all know things go wrong in a budget. And we should be able to report back next year whether we're pessimistic, cautiously optimistic, or really optimistic about savings opportunities with the collaborative.
Thank you. All good to hear. I want to ask a question about utilization assumptions. You're assuming some higher inpatient census and some clinical volumes. What gives you confidence that that's likely to keep up? And if it doesn't, how do you plan to avoid, what do you plan to do if they don't meet your expectations?
Got it. I appreciate that. I'm going to start out with some comments about inpatient volume, then I'm going to hand it back to the financial people who built the technical parts of the budget. So we couldn't help but notice in the initial staff presentation to the GMCB about the budget that most of the utilization numbers in one of those slide decks seem flat, except for the 32% increase on Gifford inpatient jump right off the page. Part of that is due to the very low numbers in previous years. Our inpatient census had gone way down to an average daily census of 8.7 in FY24. That creates an open question of like, do you need an inpatient unit or not? And so we decided to gut check that by talking with partners in the other pieces of our healthcare system, because we couldn't reconcile our low volumes with complaints of patient flow issues at other places. And so between working with our hospitalists to maintain more acute patients that would normally be shuttled off to an academic medical center, or transferring people from Dartmouth and other folks, we wanted to see whether, hey, we really need an inpatient unit, or no, hey, maybe the system needs different things. We have seen not just a blip, but a trend of inpatient admissions over time. And to be frank, those numbers could be higher, but for staffing challenges on our end, on nursing and hospitalist staffing. And so we think that these are going to be persistent, particularly if we partner with UVM more closely, and they've signaled a willingness to do that. Now, the reason why having a realistic budget is so important is this. We want to know in real time if we have a problem. And if we had a problem, as far as, hey, we had an inpatient census estimate that was here, and it's actually here, we're going to have to make cuts. My general theory of cuts is you look at administration first, because patients shouldn't suffer because you made a miss on the budget. And then for me, we're in FY26, we're going to have to go through all our service lines and see how they're performing. I think the analysis the board asked for about high and low performing margin service lines is helpful. We haven't had a lot of time to go over that as a group. But I think if we have a big miss, we're going to have to go look at, hey, what can we do incrementally, or does the situation really call for reshuffling of our service lines? We, just in case this is on your mind, we have not made any decisions about service line reductions in 26. There is not a plan to do any of that. To be very candid with you, Gifford clearly had a big financial hole to fill. What I'm trying to determine, along with the rest of the leadership team, is, hey, if we're performing better, what's really the structural problem? Because the size of that problem will determine, how much of an adjustment Gifford will need to make to achieve financial sustainability.
That makes sense. And working with our government partners, AHS and others, with the transformation planning, I think is going to be key. Thank you for your time. Thank you for your presentation. And thank you for your good work. Those are all the questions I've got.
Great. Thanks so much, Board Member Walsh. I would note that we were the first people to reach out to Rural Health Redesign. We've been working closely with them. We've been working with Kaufman Hall. We reach out to AHS regularly. We think one of the real advantages of being independent as opposed to part of one of the systems is that we could really be a partner to try things. We don't have to go through as many layers of bureaucracy or to figure out how this affects our overall multi-state strategy. We could actually be nimble and pivot pretty quickly and be a pretty effective partner.
I happen to agree with that. So, back to you, Chair Foster.
Okay, thank you. Member Teachout.
Good afternoon. I have a few
Good afternoon.
questions. And I hope they don't appear sort of micro in the sort of big picture that you're trying to address. But I wanted to start out with asking you about, you mentioned the banker's approval of your budget, and I want to know how you see that working with Green Mountain Care Board approval of your budget. It seems like, you know, you're dealing with two masters maybe perhaps right now. And the timeline for that, and then how you would address issues between the two. You know, if we approve your budget as presented or in any other modification, what if the bankers say something different needs to happen?
So I would jump in first, and then I would encourage our CFO, Cheyenne Holland, to jump in. If it appears that we're serving two masters, it's because we are. We of course have the regulatory obligations imposed by the state, which are not optional, and our bond covenants and the demands of our debt holders, which we have to meet as well. We've had no evidence so far that they're conflicting. I think we all want the same thing, which is a sustainable hospital that can meet its obligations while staying within the regulatory requirements imposed by the state. Our forbearance agreement, so we have our forbearance agreement expires soon, so we expect to hear from them shortly, sometime later in August or September, with some sort of opinion about where we go from here. And, you know, we would hope that they would say, you're on the right track, keep going. In the event that what they want from us conflicts with the budget we've submitted or the budgets that's approved, what we would do is very straightforward. I feel like I've made a commitment to local policymakers and members of the board that, hey, you're not going to learn anything in the news from us. You're going to hear it directly from us. And so I would come to the Green Mountain Care Board and say, we have this problem to solve. What do you think? Like, how do we work together? Because I really want to avoid, between us and the state and our financiers, a high leverage moment. Like, I want us to just keep doing what we're doing and make incremental progress. And so for me, we're trying to navigate the tension between those two things. I think when I talk to our bankers, and they can speak for themselves, they want to know what the plan is. And much like Board Member Walsh's question, like, they're going to ask, why do you think you can do it? And if you can't do it, what's next? What adjustments will you make? So it's a very similar conversation, actually, to what we're having today with the board.
I would
Great.
agree. And I would just add to that part of the plan from the bankers is we've had to engage a consultant to review our assumptions and then help us put together other contingency plans if we don't meet those assumptions.
I think I would just add one more thing, Board Member Teachout. You know, people, my opinion, which I have to be careful with under oath, is, you know, people bellyache about things that are still useful. You know, regulatory requirements are burdensome, but when we went into this budget process, we were able to put down two pretty notable flagpoles. Hey, this is what our bankers want, and this is what the Green Mountain Care Board guidance is. You may have feelings about how our budget should be constructed, but they have got to get through that slalom gate. And our bankers, they sometimes have useful ideas. Are you doing everything you can do on your cost report? Can't help but notice your 340B revenues down. They work, you know, the consultants that we've engaged work with lots of people. And sometimes they have really common sense and practical advice about ways to run our business that we might not be able to see or hadn't thought of yet. And so it's burdensome, but also useful because it allows us to try to pick the right improvement projects that could serve us well and make sure we get our footing financially.
Great. Thank you for that answer. I appreciate it. I have a few other things. One, you did bring up 340B program revenues, And I was wondering if you are facing some of the issues we've heard from other hospitals with continuing the program, and sort of what the future of that program is for you. Are the revenues stable?
So I would begin by noting this is one of those times where we are not similarly situated to other hospitals in the sense that we are both a federally qualified health center and a critical access hospital. And so I've heard what some of my colleagues have said about the potential end of the program from their perspective. They can speak for themselves on that. We don't see that. We've definitely seen a large drop in revenue over the last fiscal year. It's been down about 40% year over year. I think some of that is headwinds from the industry and the program, and I think some of that is our own administration. We're going to need some help unraveling that. Last Friday, we applied for a provider stabilization grant from the Agency of Human Services. We didn't ask for general cash to increase our bottom line. We asked for funds to help with consultative help and staff help to try to make our healthcare organization better. And one of those projects listed in the Provider Stabilization Fund was to take an X-ray of our 340B program. Like, because it's very hard for me standing here testifying before you to say how much is industry headwind and how much is our own operations. That's something we really need to unravel and over the next few months to try to figure out, okay, how much of a hole is there and what does that mean? We have a series, we're treating the last couple months of this fiscal year not as the end of one story, but as an on-ramp to the next fiscal year. And we picked a handful of priority projects and 340Bs on that list.
Great, thank you. I want to jump to Charge Master. I really appreciated the transparency and talking about how commercial payers are paying you. And it sounds like the 3% Charge Master increase is across inpatient, outpatient, and all professional codes evenly? Or are you doing something with the rural health redesign to your Charge Master?
No,
I would hand that to Cheyenne.
Yeah, no, our Charge Master increase is across the board, because we do know that, well, first of all, we are, for most of our contracts, we are percent of charge with the exception of the pro fees. We know that there's not, a lot of pickup there necessarily, but we wanted to put enough headroom in case there's lower of cost of or charge or lower of charge and reimbursement clauses in our contracts.
Great, thank you. And then to follow up, I saw a slide, maybe I didn't understand. You said you're moving from Medicaid fixed prospective payments to fee for service. Can you elaborate there? Yes,
so when OneCare, as of January, at the end of this quarter, OneCare sunsets, and we participate on the hospital in the Medicaid program in their fixed prospective payment. And so because our numbers are fairly small, a swing when we moved that volume, it created an area in our rate decomp that really kind of stood out, like what's happening in your reimbursement for Medicaid looks like it's really going up, but it's because we took the amount we would have received through the OneCare program under the fixed prospective payment. We said we would our assumptions that were held harmless in that, and we would receive that in fee for service. That's not to say we're not interested in exploring the Medicaid, the other Medicaid programs. We just wanted to put in our budget the impact of not having the OneCare payments.
Okay, thank you. I understand that better now.
Yeah, it's very much a reaction to the dissolution of OneCare, not a strategic decision to move away from value-based payments.
Okay, great. And my last questions are around the outsourcing, and I'm no expert on contracted services. And I understand why you would want to do it with independent living, but can you explain a little bit more about your decision to do that with radiology and OBGYN and what the benefits are for Gifford?
So independent living, I know you didn't ask about that. I would just say, though, that we have to be really good as an organization understanding when we're the expert and when we need help. And independent living is a very different thing than core healthcare services. And so we felt like it could be done more cost effectively by people in that industry. And that so far has worked out great for everybody involved, in my opinion. Radiology, it is not something we pursued. Respectfully, we had radiologists on staff in light of the Oliver Wyman report, they became very insecure about their position at a critical access hospital, and they moved. And so radiology services are critical to what we do. And so we did not have time or space to try to recruit radiologists. And so we decided the most efficacious thing was to outsource it. We contacted the local academic medical centers, who are both excellent partners. And I think they expressed some willingness to help us out. But the timing is just wrong. They have their own challenges with radiology services. And so we contracted with a national group. It's basically neutral. Kind of what we used to spend on staff and benefits is about what we expect to spend on outsourced services. But that was really a decision based out of necessity in light of individual provider reaction to that report last year, not a strategic goal of Gifford to get in that space.
And can you also talk about the OBGYN?
I'll defer to either Cheyenne or Rebecca O'Berry, our VP of Operations, to talk about that decision, which I think I started last October 1st, and that decision was made prior to my arrival.
Oh, okay.
I'm going to punt this one to Rebecca.
That's great. Thank you. The response to the OBGYN move was actually the same as what Michael is saying about radiology. We had been trying to recruit for OBGYNs, for the OBs, for a couple of years, literally like a solid couple of years, and we were using locums. And the problem that we had with locums was not only the expense, but also the continuity. And when you're talking about moving from a person who's here having a nice labor and delivery to a stat C-section, that team needs to be really sure of itself and knows how to work together so that you have a really safe transition to a C-section. So we actually decided to go out and outsource that so that we have a consistent group of people who are here. We basically look at them as if they're our own employees, although they are contracted. So we have a team of 3 people who, turn over with the 1 OB that we do have here on staff. So again, it was not a plan. It was in response to our OBGYNs leaving. Now we knew one was going to leave because when she was hired, there was a plan of her moving when her partner finished a fellowship at Dartmouth, and then the other 2 left right around COVID times, where things were just in disarray all over the world, as you know, and they made choices for their own families to relocate.
Great, thank you. Appreciate. Maybe others knew the background, but I didn't have that.
Well, and I would add 2 quick things on that. With all of these contractual relationships, I think as a leadership team, we need to demand rigor. Are we getting the service that we contracted for? Do we have performance metrics that demonstrate the value? Is it high quality care? And if not, let's move on to something else. And then I will be really curious as a board member of the New England Collaborative Health Network, where we go next. The GPO, the health insurance, other types of insurance, that's great. That's kind of the obvious stuff that you go towards as a group together. But I'm really interested in this issue of fractional and shared services. Could we do small bore stuff like credentialing, or could we do large bore stuff like how do we share radiology? How would we share other service lines? It's too early to tell, but I'll be interested next year if we're coming back with no change or incremental change or sort of big picture change on that collaborative front.
Excellent. Thank you. And the last thing I wanted to ask about, you mentioned a couple times considerations about your footprint. Are you thinking footprint merely as physical space, or are you thinking footprint as in service lines and other offerings?
I mean, when I say that, and I know there are people from Gifford watching this, so I'm not trying to break any news. I'm not trying to make anybody nervous. I think that we need to evaluate everything we do, which is both service line and geography, right? And, Vermont's a funny place. Like, just about almost half of our births come from outside of our service area. There are people driving by one hospital to give birth here. And then we also have primary care in Berlin, and the Berlin Berry areas had some real challenges with primary care. So we come into it without bias, but we think we need to do a really good job of saying, okay, what is the right set of services? What is the right geographic footprint? The reform partners and AHS have pushed us a little bit on that. We've proffered all the information that AHS and Rural Health Redesigns asked for, but we want to do it in a data-based way. Like we want to understand that question. I think also we keep pushing on partners to say, hey, can you give us some insight into Vermonters' needs? And we haven't, we don't want to be the 14th hospital pursuing the same service line. If there's some unmet need or some extreme wait time, we're happy to go try to specialize in something where Vermonters are really struggling rather than being the 10th, 11th, 12th banana. And so that's what we're thinking about. All of this relies on us stabilizing financially, which I think we're starting to collect enough data that we're getting towards that. But I think everything's on the table, within the boundary of we have a mission, we have a board, we have a strategic plan we're going to work on, and you got to talk to the community about this stuff. Like you can't make these decisions in a vacuum.
Great, thank you. Thank you to you and your team. That's the end of my questions.
Great. Member Merman?
Yeah, thanks. I have a few. So I'm trying to figure out the impact of the IT implementation, charge master, A&R, code edits, all this, whatnot. If things were running as they should, and you were to bill out your commercial, say this year, what would your commercial revenue be if you were actually able to bill appropriately? I guess, are you walking away on commercial revenue? And what is the difference between what you're making and what you would expect to make if you were billing appropriately?
Right.
So how I would describe it is we are billing our revenue out. It's hung up in denials and reimbursement, right? So we'll park sort of some of the depressed reimbursement for a second. Part of it is our days in AR. So there is a real cash issue. We would be, we were at a bottom of 59 days, we're at 66 right now. We would be, if we could unstick that, we would be closer to our covenants, which is 75 days cash on hand. That's part of the impact of the revenue cycle stick. And then I believe that when I look at my 24 performance, our collection rate was below that 50%, and we would expect to be maybe a 3 or 4% higher collection rate than where we ended. So I would have to get you the actual numbers, and I can do this in a schedule. Probably is better to see it sort of instead of, just sort of talking numbers, but seeing it in a schedule to say, if we were collecting like at 24 where we expected to be, and then 25 consistently, where would that be on the commercial side? But it's not just a commercial impact. It is a Medicare, a Medicaid. It's across all payers.
I love that question. I have driven home many a night thinking about that question. I guess why I'm pretty reserved is there was a slide that mentioned charge master problems. When we were trying to diagnose where to go with re-implementing our electronic medical record, we had an audit of our charge master to see, okay, is this a bread box? Is this a barn? And they stopped counting at 4,000 errors. And so, this basic question of, are we correctly billing and collecting for everything we do? It is still, in my mind, unresolved. And so I'm just very hesitant to speculate. I try to listen really hard to the experienced hospital leaders in our community, and I hear Tom Frank of North Country talk about all they've been through with the Cerner implementation. And when I hear him talk, I think, oh, that's us. We're behind those guys, but it's the same. We're emerging from the fog and trying to figure out where we're at and properly bill and collect. Now, I want to be careful with that talking point, because I think Gifford's management team needs accountability. We can't just say, oh, it's the EMR's fault. But I'm just Cheyenne's a little more confident speculating than I am about that.
And I would say
Thank-
that we're still working on our charge. I mean, as I mentioned in my slide, we've hit these big key areas. There are still other areas that still need to be fixed.
Yeah, I guess my concern is that if you were to be able to say overnight fix your billing and collections problem, that suddenly you're going to be a revenue monster and way below, you know, kind of where you have it gets complicated because it depends on which pricing analysis you look at, but in many ways you look like you have reasonably high prices in places, or maybe unreasonably high prices in places. And so if you turn on the machine, then the revenue is going to go up. Now, maybe you have had to have high prices, but because you can't collect on what to get the, you know, to get the revenue. So I think having transparency with the board is that system is turning on. Of course, we want you to have sustainable margins and operations, but I'd be concerned to overshoot.
We share that concern. And I would say when I think of it, I think of it on both sides of the equation. You know, once we get to that point, you know, what you do with Gifford really varies depending on whether, say, it's like a $6 million hole, a $2 million hole, a $2 million margin, or a $5 million margin, right? And so when we find level, when it comes to these issues, I would expect we'd be back in front of you saying, okay, how do we manage this now that we've emerged from that fog? And so, you know, and I very much expected questions here about, hey, you know, we've been talking a lot about limiting volume in Vermont, and a lot of your assumptions rely upon increasing access to care and volume. And that point would be well taken. And we'd expect an ongoing conversation in the future about how you manage that, depending on what the outcome is.
Another question I have for you relates to the bond covenants that are currently in violation. Is there any way to get out of violation, or once you're in violation, now you're in violation? And what's the way to get out?
Yeah, so you can get out of violation when we have our measurement periods. If we're hitting our covenants, then we would be out of these agreements that we have. So when you violate your debt, so I just wanted to first, I had this in my talking points, I think I missed it. We've never missed a payment. We've never missed a principal payment, an interest payment. These are technical defaults. So I just want to put that out there first. And so when we measure where our performance is, if we're hitting the days cash on hand and our debt service coverage ratio, we'd be in compliant with our existing covenants. To get there, though, is going to take time. And so that's why we work with the bankers, because we did default on those covenants. We are working closely with them on that ramp up of what does it take to get back to where those covenants are supposed to be. Now, that said, unrelated to our covenant default, our bankers have the opportunity within our debt agreement that they can, in April of 2026, they could ask us to redeem those bonds. They could have, even if we were performing perfectly. There was no trigger for that. That was just part of the debt agreement that we had with them.
Okay. You addressed that somewhat, so I'm not going to talk about it more right now. Shifting topics, I want to just ask real quickly about your travel nurse. How many travel nurses you use on the inpatient units? And my understanding it's a fair amount. And what's that experience been over the last 4 or 5 years?
I would invite Sarah Simeone, VP of Nursing, to talk about that. I'm not sure she'll be able to go back all 5 years, but she might be able to give us a start on this conversation.
Yeah, I can tell you our current staffing. We currently have 3 travel nurses on our inpatient med-surg unit. We have 6 today in our emergency department, but those 6 fill a total of 8 vacant FTEs. So we use them as strategically as we can. We are going to be reducing 1 more.
I guess one of my questions is that my understanding is you have had travel nurses in your inpatient unit for several years, but yet you have a 4-star Medicare report grade, which is one of only two hospitals in Vermont that have a 4-star, and none is 5 stars right now. And that reporting period, I believe, is
October of 2024.
Sorry, 2022 to 24. How were you able to attain 4 stars when I think you probably had a fair number of travelers?
So I think that speaks to a few things that we have in place. We consider our travelers representing our organization. We onboard them very similarly to how we onboard staff. They learn about the culture of the organization, and there are a number of supports in place for them while they are here on our units. We have very strong nursing leadership embedded within the units that are helping to ensure that we have educated on policies and procedures, that we're monitoring practice, and that patients are receiving the same care regardless of whether they are a permanent Gifford employee or they are a traveler.
I think that I would really appreciate, there's a lot of hospitals in Vermont that use travelers, many of them which are in this health collaborative with you. There may be an opportunity to share your experience of, we often hear that we're low stars because we've had travelers, and here you are totally throwing that rationale on its head. So I just would applaud that, but also try to take the opportunity to share with others around the state. One other topic, the shared services. Do we have I didn't see it, but maybe it's in the filings. Do we have a budget to budget change for the shared services? And do we have allocation of the shared services to the different components of the corporation?
No, we didn't. Yeah, and this was something that we didn't provide because in our interpretation of that shared services, we thought it was geared more towards those multi-hospital organizations. It is something we can put together for the board. The budget to budget allocation wasn't, or the budget to budget amounts weren't that great. So, but we would have to do the exercise.
I think it would be helpful for us to see how you're allocating it to the different components of the organization and what goes to the hospital and what goes to the other parts in the budget to budget on that. And then I guess the last question that I had for you, because we talked a bit about Medicaid and fee for service, but do you have any intentions to participate in the Medicaid global budget program in Vermont?
So we have not stated, so we're interested. I was talking with people from the Medicaid payment group last week about getting them in to give us an overview. We had some concern about the data set that we use to build our budget base because it crawls through some of the most difficult financial times for Gifford. So I just had some questions about how that would work. But we're very much open to it. And so we'll have Medicaid in to talk to us about it.
And could you remind me the timing of that decision, or is it a rolling deadline, or?
My understanding, and it was a high-level conversation, is that if you wanted to be in for calendar year 26, you'd have to move pretty quickly. I don't know if we're ready for that. I think that with all the other operational things that we have going on, I think it'd be more likely that we'd be ready to jump into something perhaps in 27. But I don't, from an operational perspective, I don't know whether we'd be able to do that now. And so we hadn't talked about specific deadlines. It was more getting more familiarity with the methodology and how the program would work.
Thank you. That's all I have.
Thank you.
Member Holmes?
Thanks. I think most of my questions were actually answered, so thank you for that, and thanks for the presentation. I think I have a couple that are just lingering, and one's just a clarification. And I think you spoke to this, but I just want to make sure. It sounds like you're planning to eliminate neurology for 26, but there are no other planned reductions. Is that right?
Oh, I want to be careful with that. We have a neurologist.
Okay.
That neurologist, for life reasons, is moving out of state, and so she'll leave our employ soon. We are looking to find a neurologist to replace that one. We are actually very optimistic that we will be able to do that. But we didn't build it into our budget because at the time, we just had no idea. We felt like the job search would either be very fast or very, very slow. And we're cautiously optimistic that we'll be able to put it in there. And so that service should stay, but it's not presently reflected in our budget.
Okay, thank you. That helps a lot. And then my next question was actually just building on Member Merman's question. If you could just, you gave us absolute numbers, but could you tell us what % of your RN staff are currently travelers?
Yes, I can. It is fractional for our med-surg unit. I mean, we have about 35 RNs and 3 of those are travelers.
Okay.
Our ED does have, right now, it'll be half travelers, half permanent staff. We have no travelers in our in our operating room or our PACU. We have no travelers in our birthing center. I think that also is really important when you think about our quality of care. The actual number of traveler nurses right now is actually relatively low in this organization.
Yeah, okay. And are there any reduction plans for fiscal year 26 in terms of the numbers of travelers, % of travelers?
Do you want me to take that, Michael?
Sure.
So as we mentioned, we do have 8 new grad nurses when we currently have them enrolled in a rigorous nurse residency program. That's standard in the industry now for how you onboard new graduate RNs. We anticipate that they will backfill the traveler positions on the med-surg unit. We know that we have interest in staff moving from med-surg to the emergency department, which we hope will then also allow us to reduce travelers in the emergency department. And as I mentioned briefly, we think very carefully about how we use the traveler hours to ensure that we're maximizing the contracts that the travelers provide us and reduce the total number of travelers we need to bring in order to cover the same number of hours of care.
Okay. Yeah. Oh, sorry. Yeah. Go ahead, Mr. Costa.
I sort of had as the new guy the same question that board member Merman had, which is, okay, we've been using travelers for a while. What's different this time? And we think the new grad residency and onboarding program is different. It's much more structured this year than we've done in the past. And then also we want to take advantage of different ways in which you could use LPNs, which we hadn't been using. And we think if we do those things, we can convert traveler positions into regular nursing positions.
Great, thank you. My next question is around the charge master. And I'm thinking as you shared that you're in the process of a very, intense process of redoing your entire charge master this year, going into next year. How should we at the board be thinking about a 3% increase to your overall charge master on what seems to be a changing base?
Right. So the actual costs and the actual fees aren't going to change as part of this process, this charge master process. Where we are struggling is where there's mismatches and inconsistencies and errors in it. As I mentioned, like for example, one code, there's a transposition error on supply codes. And so those supply codes go out, they get denied, we fight, rework it, we have to do all the stuff. Instead, it's like fixing it. So the overall pricing and our current charges aren't going to change in it. It's more around all those guts of the system that get onto a claim form. And I'll give you, and then another example, I think, to highlight, and we worked with the Blue Cross leadership on this, is we had a unit issue in some of our pharmaceuticals. And so we would go in, the price was correct for a vial, we would have a vial, and that's what we would bill and charge. They would expect so many multiples of that, like 500 milliliters. They would expect, so when they would see a unit charge, they would see a 1 at this dollar amount. The 1 was for the full vial, not for the how many milliliters it was. So when we normalized that and we did the math for them, it looked like our price was way high, comparatively speaking. And then it normalized down and said, oh yeah, it's a unit issue. So those are the things that we're discovering. It's really about reducing the edits, the errors, the rejections, and the denials that are resulted from the errors in the charge master, not the actual charges.
Okay, that is super helpful. I was trying to understand that. So thank you very
Yes.
much for that clarification. My last and actual final question is, I know you've had these EMR challenges and obviously this charge master challenge. When will you be able to update the shoppable services price transparency tool on your website? It looks like it is from 2023, not very user friendly.
Nope, we're doing it now.
Compliant. You're doing it now. Okay.
Yeah, so we're doing it now. We're working, and this is one of those when we looked at it and said, okay, internally, is this something we could get done? Yes, right? We don't have that many contracts, and we looked at all of the things that we have to do, and we said, listen, it makes more sense for us to engage a third party who's going to run through our shoppable services, our machine readable files, make sure it's compliant with all of the regs for, I want to say they're, and I don't want to throw out a number, but I think they're charging us like $15,000 to get compliant. And we're like, sold, and so they're working on it right now, knowing that as our charge master changes, we're going to continue to feed those updates to them, so they'll keep it up and going. And we expect that to be done in a couple of months to have it fully complete.
Wonderful. Thank you for that. That's all my questions, Chair Hoster.
Thank you.
Thanks. I don't have any myself at this time. I'll turn to the healthcare advocate.
Hi, Emma Zavez from the Office of the Healthcare Advocate. Most of my questions have been asked. I just have a couple. My first question, I just want to go back to the bond covenants and the contractor or the consultant. I assume Gifford is paying the consultant. It's not being paid by the bankers.
Yes.
And if yes, if you could please share how much Gifford is paying the consultant for the work that they're doing, and also if there have been conversations about separating the various entities within the obligated group.
Shane, do you want to talk? I can talk about the latter issue. Do you want to talk about the contract?
I don't remember off the top of my head how much we're paying, but we will send that information to you. And yes, anytime there is something that the bankers require us to do, it does come on our expense.
So as far as separating the entities, there's been no discussion of doing here what was done in Springfield, where the FQHC and the Critical Access Hospital became their own separate entities. There have been technical discussions internally about whether you would separate out anything in order to refinance some of the debt. So we have two major tranches of debt, one with JP Morgan and another with Northfield Savings Bank for a mortgage on our senior living campus. And, it may be favorable to us to generate cash flow to refinance that, but it's within the obligated group that's under the forbearance. And so we need to have a discussion with financial partners and bankers about, would it be advantageous to all of us to try to refinance this in a different way? They're in the discussion stage now. I'm not going to pretend know more about those transactions than I do, but it hasn't been in service of creating separate entities to run it differently for the community. It's been, could you enable a financial transaction that could help financial sustainability?
And as Michael was talking, I looked up the contract, and we are for this particular report, it's 35,000 plus fees, plus like travel, if there is travel and things like that.
Thank you. That's helpful. Thank you. I just had one follow-up question to Member Teachard's line of questioning regarding the contracted providers. I think you had mentioned that the radiology contractors was essentially revenue neutral. I was curious about the OBGYN contracted providers, if that has come at a larger expense, or if that's also revenue neutral, and if there are plans to try to recruit again for permanent employees.
This happened in previous budgets, and so I don't happen to know the answer to that. We could try to find that answer for you. we are having an ongoing discussion about what are the right areas in all aspects of our business, both clinical and non-clinical, about what's the right area to recruit and what's the right area to contract out or partner and collaborate. So I think as we review all service lines, we'll take a look at that contract. Those are among the largest contracts we have, and so they deserve a lot of scrutiny. We do not, I don't have any more information on that right now.
That's all right, thank you. My last question. So over the winter, the Vermont legislature debated capping the price of outpatient infusion drugs at hospitals across Vermont. We heard from some hospitals that they would have to turn away patients. And so we were curious if Gifford has the capacity to provide outpatient infusions to additional patients.
I would defer. I have a view on that question, but I would defer to either Rebecca, Sarah, or Meg if they would want to weighed in from an operations standpoint. So I believe the answer is yes. I believe that we could serve more infusion patients. I don't think that would be a big lift for us, but I would like my colleagues to weigh in as well.
Yes, so we do currently provide infusion services, essentially in our PACU space. And yes, there is capacity to increase the number of patients that we see on a daily and weekly basis.
Thank you.
I mean, it creates the larger point, Emma. And I know this is not novel. There's only two ways forward in healthcare. One's competition, the other is collaboration. Given our small size and the fact there's a mountain range in the middle, the way forward is clearly collaboration in Vermont, which to me makes it about proper allocation of resources. There are some things that Gifford should do well and specialize in. And I think that's one of the ways in which we can be meaningful to Vermont's overall healthcare system by providing pressure release valve when that's needed. To the point that starts throwing off, if it ever threw off a lot of revenue, to Board Member Merman's point, we'd be right back having the conversation of, all right, what is the right place and the right care at the right time at the right price to contribute to Vermont's ongoing project to affordability in healthcare.
Thank you. That's all the questions I've got. Thank you.
Thank you, Emma. I'll open it up to public comment. Okay, hearing none. Any old or new business for the board? And I will move to adjourn.
Second.
All in favor, say aye.
Aye.
Bye.
Aye, and we are adjourned.